Welcome to the Listen Up podcast, where we explore hearing loss, communication, connections, and health.
Hey everybody, Dr. Mark Sims here. I'm the host of the Listen Up podcast, where I feature top leaders in healthcare. This episode is brought to you by Listen Up Hearing Center. I help patients to effectively treat their hearing loss so that they can connect better with their friends and family and remain independent. The reason I'm so passionate about hearing loss is because I lost my brother Robbie twice. First, from his hearing loss to radiation to his brain tumor, and then when he passed away. I only care for ears. I'm the E of ENT. I've performed over 10,000 ear surgeries over the past 20 years and taken care of many more with hearing loss. I'm the founder of Listen Up Hearing Center. I'm an author of the book as well, Listen Up, A Physician's Guide to Effectively Treating Your Hearing Loss. If you want to learn more about that, go to listenuphearing.com. Today I have a great friend and guest. It's Dr. Oliver Adunka. He's the Director of Otology, Neurotology, and Cranial Surgery, Department of Otolaryngology, Head and Neck Surgery at The Ohio State University. Dr. Adunka is the outgoing chair of the board of directors for the American Cochlear Implant Alliance, which is a very important and excellent organization. His research over his career is focused predominantly on cochlear implantation and hearing loss, and we're excited to have him as a guest. Oliver, thanks for coming on the show.
Yeah, thanks for having me.
Sure. Tell me a little bit about, your story. In other words, now you're this, skull-based surgeon, otologist, guy who does cochlear implants. Maybe you were born that way, but at some point you probably got to the point where this is what you decided. How'd you end up in this space, the space that we're both in and passionate about?
Yeah. Thanks again, Mark, for having me. So as many of you recognize the accent, so I grew up in Austria. And
that's not a Brooklyn accent.
Sort of, urban Austrian accent, I guess. So, I sort of slipped into medicine via the engineering kind of pathway. That was always something I was interested in. And my dad's a physicist, so I always, that was sort of my natural strength, if you want. And ultimately, in medical school, became interested in, neurosurgery and other fields, but ultimately stumbled into cochlear implants and, really the gift of hearing, I guess, and that was in the 1990s where, again, cochlear implants were just in their second or third generation devices, right? I mean,
really for your listeners, really in their infancy, they were not commonplace. Yeah. They were just kind of increasing in prevalence. It wasn't
right. Exactly. Yeah. So I remember, the surgery was more involved, right? Back then, it was more of a kind of big deal in a way to get a cochlear implant. And subsequently, let me just mute my computer here. I've been sort of part of this journey that we all have been part of, that cochlear implants have become just much more, I would say standard of care, although, we still struggle with getting that word out. But yeah, my path has always been the engineering and the research path. And, was ultimately really fascinated with what we do as the sort of merger of engineering and the human aspect of practicing medicine, and then the surgical aspect, of course, but really the human aspect merged with kind of natural sciences in one way or the other. And so that's really what drew me into it. It still does. So I've been involved with cochlear implants ever since I wrote my doctoral dissertation back in Austria. We had to do that in order to graduate med school, and that was on cochlear implant outcomes. Now you would look at that, you're like, well, duh, we all know that, but back then.
And it's only after it's been proven do we know that, right?
Yeah, so that was sort of, that was my topic. And sort of been just really grateful to see, how the journey of the device of cochlear implants and what we do in the field, really kind of fascinating.
Yeah, I mean, there aren't many medical devices that the user feedback is part of the care, right? And so, I mean, pain management, sensory management, but, there's not a lot of user feedback in terms of, I don't like how this hip rotates or those types of things. So it's a fascinatingly different field, right?
I would agree. Mm-hmm.
Yeah, and so what type of work are you doing now in the field of cochlear implantation, Oliver?
So, I was really through my mentor back from, Europe. I was always interested in electroacoustic stimulation. So combining residual hearing remnants and preserving that with the cochlear implant, really. And that obviously was meant to open the door for more candidates, meaning broadening candidacy criteria, implanting folks who are not just really deaf, right, profoundly hearing impaired, but folks who have some residual hearing, but who really struggle with, again, connecting with their friends and family and at work, etc., and helping those folks gain access to a cochlear implant maybe sooner. For me, when I see patients in clinic, and I'm sure it's the same for you, that a lot of folks have residual hearing, and we all know folks get cochlear implants too late, adults and kids, right? People wait too long, and so really getting that intervention to folks early, I think, is absolutely critical, right? And I think something that has to happen is that folks don't need to feel like they don't give up anything, and giving up that residual hearing that may still be useful for them in the middle of the night when the dog barks or the fire alarm goes off, or you hear a siren. But that hearing is really not helpful for communication. But making sure folks don't feel like they need to relinquish that to get the, gift of hearing for a cochlear implant, I think is absolutely critical, Brian.
Do you think that's a large obstacle to people doing it?
It's certainly one of the obstacles. It may not be the biggest obstacle. There's several, when we looked at that, the American Cochlear Implant Alliance, certainly there are perceived financial obstacles that are not necessarily factual, depending on the patient's coverage. There's certainly the obstacle of surgery, right? And the obstacle of surgery also is not necessarily correctly perceived, because someone like you and I can easily perform a cochlear implant in under an hour. So there's some of these smaller obstacles, I would say, and as we and you've been really at the helm in this effort, right, is to make the process of receiving a cochlear implant just easier. I feel like a lot of my patients are overwhelmed with these this series of 6 ninja moves in sequence to get a cochlear implant, and folks just feel like, well, I need to go there, I need to get a CT scan, and I need to select my device, and then I need to go to anesthesia, then I need to meet with you, and then it's just so many steps, right? And I think we as a field, it's probably good advice, to make that process a little easier and more accessible.
Yeah, so I would use, for me, at least for our process, I would say it's more streamlined.
Yeah.
To be honest with you, maybe more streamlined for us. And so, personally, I look at some of the hurdles of candidacy as a representation of desire. Yes, I mean, there is a certain corpus of information and processes that need to be gone through. And whether, I don't know where you can actually minimize it. My big thing is self-education. I really think people need to educate themselves in the pre-implant process, meaning really know what they're getting themselves into pre-implant, so they're not disappointed post-implant. Because I don't think many cochlear implants don't work. I think many cochlear, perhaps when people say that, they actually mean it didn't do what I expected it to do. And when it didn't do what I expected it to do, I probably didn't have good preoperative expectations, which is a really hard area, as you know.
Yeah, I agree. I think, I really have little to add other than, providing patients this information is critical, but also difficult because Dr. Google and other information sources are not necessarily consistent. So I think that's where we come in, right, as our practices and really kind of...
Agreed. No, agreed. But a little bit of I think one of the downsides of hearing loss is it robs people of their freedom, right? They become codependent on other people to do stuff. And then as we restore their independence, we almost continue to perpetuate that lack of independence as we kind of, for lack of a better word, spoon feed them the process, right? And so I definitely want them to take ownership. That's part of the process, I think, of getting it out to more people, is having more champions. But I agree with you 100%.
And then I think tying back into what you said earlier, I think, hearing loss is so socially isolating, and just this feeling of defeat that a lot of folks have really is hard to overcome sometimes. And, you and I see this in our practice all the time that, family members almost have to talk people into getting a cochlear implant, So, and I think it's great to see that family support system on one way, but it also documents how hard it is for some folks who are stuck in this depression really to get out of it.
Yeah, well, obviously we all operate from our own perspective, right? So I saw 2 patients today, one, from a bit of a distance, and explained that they'd need multiple trips in the first year. And the person with the hearing loss was kind of pausing. The wife said, "Don't worry, I'll do it." Right. So she's more motivated than he is because of the impact on him. And then the other interesting one was a woman with hearing loss who was frustrated because her husband didn't realize how frustrating the hearing loss was for her. And I said, yeah, but he's also repeating himself over and over again. And so it's really a mutual loss within a couple, right? That it's so impactful on both of them. And
I remember going back to, when I trained and, I knew about cochlear implants through my research and all that, but then really practicing myself and, being these people's doctor essentially and having sort of, more meaningful conversations with them before and after was really kind of insightful to me,
Yeah, no, it's a liberating technology for the right people. And so, that actually touches one of the things. So one of the things I wanted to get out there, and I know you're rotating off as the chair of the American Cochlear Implant Alliance, and thank you for doing that, is one of the victories was an expansion of Medicare criteria, correct?
Absolutely, yeah. So CMS expansion study, Craig Buckman and Terry Zwollen have led this effort. It was a multi-year process, which just documents how difficult it is to do these things. Right. And a great study across multiple sites. I think we had patients in there as well. And really, it proved sort of the safety and efficacy of this intervention for folks who have residual hearing, right? Who have word scores that are a little higher than what we previously thought we could tackle, right? And really, for your listeners, maybe, our cochlear implant indication criteria are so conservative because every physician's nightmare is to make anyone worse, right? And they're so conservative because this way we can almost guarantee that you will do better, like you said earlier, right? I mean, there are some people who don't do well with cochlear implants, but it's very rare, right? And we really want to keep that number darn close to 0. So I think that's the history of this, and then obviously as we learn to use the technology, and the technology has improved some too, but as we learn to use it better clinically, I think we've learned who will do better and who won't, and the recent widening of the indication criteria, meaning the widening of the pre-operative ability to discern words, is really a product of that.
So for the listeners, the criteria now is not that your hearing has to be good, but your hearing is less bad, yes, and still qualify for a cochlear implant, right? And so in terms of expansion, I don't know the numbers. Do you know the numbers of how much it expanded the population of Medicare recipients? It's okay if you don't. I was just actually...
I don't know the actual numbers, but a few numbers if we look at the percentage of cochlear implant candidates who actually receive a device. If you look at traditional criteria, meaning pretty narrow criteria, meaning you have to be pretty much deaf or really close to, is about 3%. Is about 12% of traditional candidates receive it. And that number has crept up very, very slowly. So we do make a dent in the number of people who get a cochlear implant versus the people who could qualify, but it's very slow. For traditional criteria, for expanded criteria, so if we widen that net, only about 2 to 3% of folks who could get a cochlear implant with those expanded criteria are actually getting it. Right.
So one of the things that's interesting for the listeners, there's FDA criteria, which is the Food and Drug Administration's criteria that they approve, that the companies ask them to approve for. And then Medicare, which is another federal agency, has its own criteria where it evaluates the clinical efficacy and the economic impact of it within the population that they serve, which is predominantly the elderly population who are Medicare recipients. So the criteria are really different. That one thing about the expansion, correct me if I'm wrong, Oliver, is it is more in line with the FDA criteria now as compared to before, where the understanding had to be much worse for Medicare.
Correct. And what ultimately happened is that folks were sort of marginal candidates with a device labeling with the FDA, what you mentioned, would have qualified them, but the problem is no one would have paid for it. So they were outside of CMS criteria. And so especially Medicare. And as not all states, pay for cochlear implants who have Medicaid insurance. So it's certainly has helped us with that. But we need to get the word out. If you actually look at, we all talk about these expanded criteria, but if you look at who actually gets a cochlear implant, right?
Far down.
The vast majority are still bilateral patients with bilateral hearing loss, right? So I think we need to get in. Cochlear implants work better if you get them early.
Your hearing loss is not.
Yeah, if there's not like that. But yet we mostly implant folks who have really severe levels of hearing loss. So I think we need to get to implant, get to folks earlier, right? And part of the barriers that we talked about earlier is that hearing loss is a hidden disability. Like as you said, the example you brought up with the husband and wife, and I mean, all of us see that constantly, and it's just such a disabling disability, but yet no one can tell that you have it until you have a conversation.
Right. Yeah, it's not seeable, that's for sure. And so, I know that you've done some research also on single-sided deafness. So one of the FDA criteria is for single-sided deafness. What's the state of Medicare criteria for single-sided deafness right now? Just,
So it's not, it's really not part of it, right? The device labeling for two of the manufacturers includes single-sided deafness that started in 2020. So during the pandemic, it's really difficult because in adults, I would say.
In Medicare, I'm just talking about Medicare.
Oh, Medicare. Yeah, we're not allowed to, for example, if you have a single-sided deafness Medicare recipient, despite the fact that, again, the FDA would allow us to implant the device, Medicare does not cover that as a benefit. Right.
So for the listeners, there's a difference between what you can get clinically and what Medicare is willing to reimburse for. And so those are different criteria, right? And so
there's some supplemental plans, where you have folks that are 65 and over who have single-sided deafness, who you can implant if they have a supplemental plan with Medicare. So there are some exceptions. It gets really complicated and esoteric. I have to constantly ask our office people, whether or not I can submit it, right? If most of the times we can't submit it to insurance and get prior authorization. So private insurance is a lot different. A lot of private insurance, I think Aetna was the first one that really approved it. And, a lot of others have followed suit. United recently, changed their criteria. So we're glad to see, at least the private industry following this. But yeah, Medicare is still a big ask.
Well, I mean, I said, in Medicare's defense, I think they always want to take care of their beneficiaries well, in a data-supported and fiscally viable way, if that makes sense. And so I assume, is there a work afoot to get the needed information for Medicare, or is that a big lift and we're not there yet?
No, it's there are some efforts. We had calls when I was with the American Cochlear Implant Alliance. So there's some work, both with the FDA to lower the age for kids for single-sided deafness, but also with CMS on the other side to include coverage of single-sided deafness. So yeah, there are efforts. As we can see from the CMS expansion study, these are not quick, but we've started to work on this.
The CMS expansion study was 7 years.
Mm-hmm. I think so.
7 years or something like that. So for the listeners, collecting good, clean, reliable, consistent data, while Dr. Adunka is busy actually just getting through clinic and making sure he's not running too late and keeping patients happy and making sure everybody's safe and all of those things is very, very challenging. So kudos to the centers that actually collected it all. I think it's
absolutely. It was a big lift, and again, we hope that it has a clinical impact that we can all feel.
Yeah, well, I think it will. It might take. I mean, I think there are probably some people that immediately affected, and then some others. I can tell you, for us, when we're evaluating, obviously, I think we're getting more people. How can I say, within criteria, easier.
Yeah. No, I would echo that. Yeah.
Yeah, you don't have to give as much background noise to get them to meet criteria. And so how about the other question I get asked all the time about Medicare is an implant in the opposite side. So in other words, a second side implant. What's the status of that with Medicare?
I mean, we offer that at Ohio State, right? I mean, Ohio has so Medicaid is state specific. Medicare is federal, obviously. Right. So we're in lucky position that we can offer Medicaid implants for second sides. Frankly, I have to look up the specific wording and all that. I usually ask again our clinic manager, and they know all that information a lot better than I do. Typically speaking, if someone has one implant, a lot of adults only want one implant, right? So that's unfortunately, or it's just a reality of the situation. But some of my patients do come back and want a second implant. Certainly, we recommend it. 2 years are better than one. The other question oftentimes is how much that condylateral ear, how much residual hearing is on that side, and a lot of people still like natural hearing to be left, to hear sort of certain environmental sounds. So,
great. So where do you see cochlear implantation going in the next 5 to 10 years, Oliver?
Yeah, I think we need to find a better way to predict performance in cochlear implants. Right now, again, what we mentioned earlier is that our clinical algorithm is really geared at not making people worse. But if you have a patient in clinic and they have residual hearing and they're 60%, but you can guarantee them 85%, right? That's a much easier sell than if you say, hey, you may be at 60 to 80%, right? And I think we need to be better at being able, again, predict cochlear implant performance much more patient specifically. So I think precision medicine is sort of the term that's thrown around all over. And I think precision medicine needs to find its way into cochlear implant. We need to get better tests, electrophysiologic tests, etc., that would allow us to predict cochlear implant performance much, much better than we currently are. And if we can do that, we can set expectations, like you mentioned earlier. We can really set very specific expectations on how this particular patient will perform. We're also, yeah. So
it's interesting, though. My struggle always is do the patients interpret these numbers correctly? Like, what does 85% mean to a patient as compared to us, right?
And it's hard to. I completely agree, and it's oftentimes in clinic, if a patient's sort of on the fence on whether they want this or not, right? And I'm like, okay, let's sit down. We usually print out the audiogram and we look at the aided speech testing and the numbers, really unaided and aided. And we say, hey, this is where you are right now. This is what a cochlear implant will likely get you, recognizing there's a real range. And what is the chance of making you worse, right? What is the chance of making you better? How much work do you need to put in to train yourself to be at that point, and how long will that likely take? And we talk about all these topics. I think there's some real life kind of conversations that happen about the effort that a patient needs to put in to get a certain result. And it's almost like if you get a new knee, right, and how much physical therapy you need to do, right? But although for a knee, everyone feels like it's just what you need to do, right? But for this, it's like we get a little bit more headwind on that question. So
I use the analogy of learning how to play an instrument, right? So when your parents go out and buy you the violin, doesn't mean you know how to play the violin, right? I mean, having it and you knowing how to play it.
Yeah, it's a great analogy, and certainly something my kids tell me all the time about pianos. Yeah, so
right, and so I mean, it's about work, right? And so it's sitting down.
It's work. And I think one of the factors some audiologists mention all the time, and I think it's worthwhile talking about, is patient motivation. And I think you also touched on that previously, where you said, hey, it's going to take some effort. It's not going to come out automatically, right?
Yeah. So, we lay out a path, and our answer, I tell patients this, like, if you see this path and you decide this path isn't right for you, we support that and we actually are okay. And I'd say probably about 1 out of 30 says, you know what, this is too much for me in my stage of life and doing that lift. And so, whether or not, the patient should or shouldn't do it, I think is one issue. I think for societal resources, it makes sense too, right? Like, we don't want to put cochlear implants in one person who's not going to use it at the expense of somebody else not being able to get one. And so it is a very expensive undertaking. I mean, highly valuable, but it's expensive. And so we need to make sure like the people we're putting it in are actually going to use it, right? And that's why parents rent instruments before they buy them, right? So not a piano perhaps, but when your kid plays an instrument, you oftentimes will rent it for a couple of years to make sure it's really going to take before you go out and actually invest in buying the instrument.
You've done that too with other instruments.
Some of them end up in storage with less of them, right? So
absolutely. Yeah, it's a good point. It's but I think going back to our inability to correctly or to accurately predict cochlear implant performance is part of a barrier, right? We can just guarantee. I mean, let's just say the patient understands these numbers, right? And we sit down, hey, and now you're at 30%. We pretty much can guarantee you 60%, is that enough, right? But if we can so I think, I don't know, it's hard. And every human being is different too, right? Then you walk in your door. Some people have different kind of trigger points and other.
Yeah, we're big believers in crowdsourcing. And so what I mean by that is I tell everybody to go on Facebook and talk to people.
Yeah, absolutely.
And, I always tell them like, the clinician's perspective is valuable, right? Because we're part of the team. But getting other patients' perspectives, that's the answer, right? For us, at least. Because
I mean, that is so powerful, and I couldn't agree more with you on that. Right?
Yeah, I also, the thing that's I think amazing is people are willing to answer almost any crazy question you will ask on social media, right?
Yeah.
If you want to know how much cochlear implants will improve your love life, somebody will tell you, right? And that's not anything I have, knowledge from my patients. Nobody shared that with me, but that is the beauty of social media. People want to be social and they want to share their collective experience, as long as obviously they're comparing apples to apples, right? Yeah, that's one of the.
Yeah, we have a pool of patients. We ask every patient, hey, would you be willing to, share your experiences with candidates, essentially other patients, and I think it's very powerful. I completely agree.
Yeah, that's great. And so, Alvaro, what's your favorite sound?
I would say, having kids myself, I would say it's a baby crying. It's very annoying at times, when it's excessive, but it's a new life, and it's a great sound.
That's awesome. So, Alvaro, if people wanted to get a hold of you or find you, how would they find you?
Really just through the medical center website. My contact info is all there. My email is on there as well. So I think a lot of folks who potentially need a cochlear implant can't necessarily pick up the phone and talk about themselves, right? Maybe have a family member do it, but email works fine. I answer them all personally. I'm sure we all do. And I think, we want to provide access, right? Access for us is, it's a big topic in medicine. I'm sure you do as well. So we want folks to have access to us, not just as new patient, but also as established patient, right? Sure. We want to make sure people are not feel like they're left out, in the jungle alone. So it's
already lonely enough.
Yeah, or in the desert in your.
That's correct. And a very hot desert it is for the listener. It's mid-July and it's relatively warm. For everybody, this is Dr. Oliver Adunka. He's a professor and he's a director of otology, neurotology, and cranial surgery, the Department of Otolaryngology, head and neck surgery at the Ohio State University. So if you go to Ohio State and search the medical center and search Dr. Adunka in the ENT department, I assume the Google search engine will take you there, and he's open for questions. He's done wonderful work in advocacy and clinical research. We really appreciate your efforts, Oliver. Thank you so much.
I appreciate it having me. Thank you.
Sure. And thanks for coming on the show, and I appreciate your time.
No problem. Thanks, Mark.
Thanks for tuning in to the Listen Up podcast. We'll see you again next time, and be sure to click subscribe to get updates on future episodes.